Dear friends, I am going to talk about endoscopic interlaminar lumbar disc surgery. This is one of the method of treatment of lumbar disc disease or even lumbar canal stenosis. Other being transforaminal, and one can also do biportal surgery. There is nothing to declare. The lumbar disc disease is quite common. Majority of them can be managed by conservative treatment, but the indication for surgery are when the patients are not managed by the conservative treatment, or when there is a progressive neuro deficit, then you require surgery. This can be done when there is unilateral symptoms or bilateral symptoms, but I will advise that for beginner, it is better that you choose simple case. That means when the symptoms are unilateral. It can be done at a single level or multi-level. It can be used in highly migrated disc. It can be done in lateral disc, central disc, extra-foraminal disc. But in extra-foraminal disc, we need to take a different course. It should be in between the two transverse process and not the interlaminar. A recurrent disc also can be treated, calcified or fibrous disc. It can be done at all level, including L1, L2 to L5S1. And you can treat lumbar canal stenosis, but the contraindications are when there is unstable spine. You need to fuse such cases, and when the level extends to 3 level or more, although it is a relative contraindication because the duration of surgery exceeds. For single level, it usually take about 1 to 1.5 hours. So up to 2 level, I do this endoscopic surgery, but 3 level and more, I avoid doing endoscopic. There should be good clinical and radiological correlation. And this point is important because in most of the time, the radiology looks very extensive. In radiology, you may find multiple level compression, whereas clinically, these are only 1 or 2 level which are responsible for patient symptoms. One should study in detail the MRI and CT scan to find out what all structures are involved and what you need to do before surgery. So in your mind, you should be very clear what are the different pathology and what you have to do. So find out the status of the spinous process. You should know whether the tip is angled or it is curved, or sometime the spinous process tip is broad base. In this photograph, you can see that the spinous process is quite bulky, and at times it is tilted. Here in this case, it is tilted, so it becomes difficult to dock your tubular retractor on the ipsilateral side if the symptoms are on that side. What is the situation of the lamina? Whether these laminas are horizontal as is here, or these are more vertical, which occurs in upper lumbar spine. So if the lamina is vertical, then also there is a difficulty in docking the tubular retractor, and you have to use some other methods to drill the vertical lamina and dock the spinous process, dock the tubular retractor at a proper place to do surgery effectively. You should also know the location of prolapsed disc, whether it is a central disc, lateral disc, foraminal disc, or there is a migration of the disc up or down. Whether the disc is hard or soft, all these things matter. Whether there is an osteophyte, what is the location of the root, what about the ligamentum flavum, whether it is hypertrophied, and what is the status of the facet joint. Here you can see that in this diagram, the facet is hypertrophied, and here also the facet is significantly hypertrophied. So these also will hinder in proper docking of your tubular retractor in the interlaminar approach. In this diagram, you can find out that the interlaminar window is very important. So this is the distance between the lateral margin of the spinous process to the medial margin of the facet joint. So this is the distance. If this distance is very small, like when you have hypertrophy of the spinous process, if it is bulky spinous process, or if the facet joint is hypertrophied, in such cases, this distance will be significantly reduced. So in such cases, your tubular retractor will be placed too much laterally, and there will be medial angulation when you try to dock it. And when there is too much of medial angulation of your tubular retractor, surgery becomes difficult. There should be sufficient window distance between the lateral margin of the spinous process and the medial margin of the facet joint that you should see in the plain X-ray. The type of disc we should be all aware of before surgery, whether it is a shoulder type of the disc shown here at number 2, or it is axillary type of the disc, or it is a ventral type of the disc. If the disc is placed ventral to the root, in that case, the root will be displaced posteriorly. And such cases, there is a risk of injury to the nerve root by Carrison punch, because the root is displaced posteriorly, as shown here. Because of the ventrally placed disc, it has been pushed laterally, and if you don't use Carrison punch properly, then you might catch the root and cause injury or CSF leak, injury to the root or CSF leak. In the procedure, the patients are placed in the prone position. It is done under the radiolucent table so that you can take X-rays using C-arm, generally under general anesthesia, but you can also use local anesthesia. These are the different positions which people use for lumbar surgery. I use prone position with the bolster on the side so that the position of the patient is as natural as possible. I don't go for too much of flexion. The sets, different type of sets provided by different companies are available. One can use different kind of things, but one thing is common, these are all tubular retractors. So you can use Endoscopic or EasyGo system, or there are many more systems available in the market. One can use any of them, and all of them are quite effective. You require proper localization where you need to make incision. For that, one can use the atraumatic localizers as shown here, which can be moved in 3 directions. These arms can be angulated cranial caudally, and one can place them cranial caudally like this. So the localization is done, but it is very important that both arm of the localizer should superimpose. This can be seen here. Both arm, one arm is here, another arm is here. So both arms should superimpose at the level of surgery. If you see only one arm at this level, the other arm is at some other place, that will be the wrong localization. So both arms should superimpose with each other. The other point is that these arms should be about 90 degrees. Don't keep too much of angulation of these arms. If it is angulated cranially or caudally, then one can realize that these arms are at this particular location, whereas the skin incision may be either more cranially or caudally. So you have to work at it at an angle which is difficult during surgery. This can be explained more easily in this diagram. If the spinous process are more lordotic and you have to go through the middle of the disc for localization, so your arms are going like this, and the skin incision will be more cranially placed. So the skin incision and the disc should be at the same level. So for that, it is better that this lordotic curve should be corrected and break the table so that your localizer pin also goes through the center of the disc, and the skin level and the localizer pin level uh, should be at about 90 degrees, rather than having too much of angulation. If there is too much of angulation, the soft tissue will peep inside the tubular retractor, and surgery at acute angle is always difficult. Whereas if the angle is orthogonal, then the surgery becomes simple. One can also use LP needle for localization of the lesion. You should mark the midline and also mark the level of pathology as shown here. This is the midline, and this is the level of the pathology which has been marked. The small skin incision of about 1.5 to 2 centimeters is given, about 1 centimeter lateral to the spinous process. The fascia is cut in the direction of the skin. Paraspinal muscles are separated from the spinous process. This is done in the descendo technique, but one can go through the muscles. So this is the dilatation technique, which is utilized in easy-go system and other technique also. So either of these technique you can utilize. The soft tissues over the lamina and the facet joints are removed, and then after that one should go for resection of the bone part of the superior lamina up to you find the attachment of the ligamentum flavum on the under surface should be removed, and little bit of the inferior lamina also need to be removed to take the ligamentum flavum. And the medial portion, the facet joint also can be removed so that there is sufficient space for you to manipulate, and you don't require too much of a retraction of the root, which may cause complications. So to removal of the lamina and the facet joint, you can use burrs, or you can use trephine or rongers. This is a short video of L4-5 disc. This is the quite large disc which is there on the left side. Patient was having symptoms on the left side, and this is after the surgery. You can see that the disc has been removed and the patient symptoms improved. So this is video which is showing the removal of lamina. This is the cranial part, the caudal part, medial and lateral. So Carrison punch is being used to remove the superior lamina, that is L4 lamina in this case, and with angled hook, the ligamentum flavum is separated from the dura to prevent injury by putting in the patties in between the ligamentum flavum and the dura, as we do in the routine. And now the separation of the disc from the thecal sac and from the root using the angled hook, and the disc is removed. The further disc is removed. Here I want to make a comment that it is always better, rather it should be a rule that you should try and take out the disc fragment first, rather than mobilizing the root to the side, because the root is already stressed and it is compromised. And if you try to retract the root, stretched root, then these patient can have some nerve injury because of the stretching. So one should avoid retracting the root when it is stretched. So first take out the disc fragment, and once it becomes lax, root becomes lax, and after that you can move it slightly to either medial side or lateral side, depending upon what you want to do. And now this is the example which I have tried to explain, that if there is a central disc, then how to remove using tubular retractor. So this is the tubular retractor, this is the massive disc, this is the compromised thecal sac. So how to remove this disc? Remove the disc from the ipsilateral side. This is quite simple. So take out the disc, empty the disc cavity significantly, and then push the disc fragment, central part of the disc fragment, inside the disc space. So with right angle dissector, rather than trying to take out the disc fragment from here through the tubular retractor, you must push the disc fragment inside the disc space, and so central disc can be pushed. The other side also, the contralateral disc fragment also should be pushed inside the disc cavity and take out this fragment from the ipsilateral side, rather than going over the top or trying to remove these disc fragment directly and causing stretch on the thecal sac. So push the disc fragment inside and take it out. Now this is the diagram which shows if there is a bilateral compression, how to remove the lamina. So ipsilateral lamina, the facet joint can be removed, and the opposite side lamina can be undercut by angulating the tubular retractor as shown here. So under surface of the opposite lamina can be removed, when you are doing bone work, keep ligamentum flavum intact. So ligamentum flavum should not be removed first before removal of the bone, otherwise there is a risk of dural tear. So this ligamentum flavum protects the dura from dural tear. So remove the bone first, keep the ligamentum flavum intact. And the way I use to remove the undersurface of the lamina is shown here. This is the lamina. This is the undersurface of the lamina. This is the outer side. So I make the drill just like this, more near the inner surface of the lamina. So making a drip, doing a drill and leaving small little of the lamina intact, which is adjoining the ligamentum flavum. So drill this and then remove this the axle lamina using Harrison punch or micro dissector, and the process continues. The advantage of endoscopy over the microscopic technique is that there is a better visualization. It is minimally invasive, reduce the hospital stay, there is a lower cost, and it allows observers and the operating room staff to be more involved, and it is good for education purpose. There are limitations of endoscopic surgery, steep learning curve, increased complication rate, more operative time, especially in the initial learning curve, and there may be conversion to open procedure. These are some of the examples. Preoperative MRI showing L4-5 disc, and this is the post-operative image showing good decompression. Another case, two-level L3-4 and L4-5 compression with canal stenosis, and this is after surgery, good decompression, bilateral decompression. This is 3D reconstruction showing removal of the two level of the lamina. From unilateral approach, the bilateral decompression has been achieved very significantly. So what are the results? The surgery provides faster pain relief from acute attack as compared to conservative treatment. At 1 year, the result of surgery is far better than the conservative treatment. There is a 90% good results compared to 60% of the conservative. At 4 years, surgery also fares little better compared to conservative treatment, but the difference is not statistically significant. At 10 years time, the results of surgery and conservative treatment are same. So what does it mean? The surgery has a role for acute pain relief and early return to the work, but there is a role of continuous care of back in the form of good physiotherapy and good posture. So if you just do a surgery and forget about the proper care of your back, then at long term, the result of surgery and conservative treatment becomes same. In the complications, there may be dural tear, pseudomeningocele, CSF leak, persistent paresthesia, especially when you try to retract the root when there is a large disc fragment which has stretched the root. So stretched root should not be retracted. There may be meningitis, and one can do wrong level, especially when you are dealing with L4-5 and L5S1 disc, because slight cranial or caudal angulation, one can reach L4-5 level or L5S1. So the complication avoidance, CSF leak is one of the complications. It is more common when there is a severe canal stenosis, when there is a large central or extruded disc, or there is an inferiorly migrated disc. In such cases, the dura is pushed posteriorly, and there is a risk of injury to the dura. And when the disc is migrated inferiorly, then the dura is not protected by the ligamentum flavum there. So there is more risk of dural injury when the disc is inferiorly migrated. When you don't properly use Harrison punch or drill, especially for cranial work, one should use 45-degree Harrison punch. For caudal work, it should be about the Harrison punch should be 90-degree angulation. It is more common when there is a resurgery because there is no flavum and the scar tissue is adherent to the dura or to the root, and when we are dealing with the opposite side pathology. So apart from the other methods which we have already discussed, one should try to separate scar from the bone and not scar from the root or from the dura to avoid dural injury. The other complication is root injury and paresthesia, which we have partly discussed, and this occurs when the root is pushed back by the ventrally placed disc. And in severe stenosis, recurrent disc, foraminal stenosis, and retraction of the stretched root without the disc removal. So never ever try to retract the root when it is severely stressed by the ventrally placed disc. So first remove the disc, and inferiorly migrated disc I have already discussed because there is no protection of the ligamentum flavum, and there is a high risk of root injury. There is a thickened ligamentum flavum. So these are the example. The ventrally placed disc is pushing the root back, which may be injured. And when there is thickened ligamentum flavum, the roots are severely compromised. And if you try to decompress this ligamentum flavum by putting in Harrison punch from the medial side to remove this ligamentum flavum, then there may be injury to the root. So you do not put it from the medial side. Try to decompress the thickened ligamentum flavum by using a fine Harrison punch from either cranial or caudal side where there is more space. The other complication may be incomplete decompression, and there may be recurrence. Patient may continue to have pain post-operatively. So this happens when the small disc fragment has been removed, when there's a significantly large disc prolapse. So if there's a large disc prolapse, then as shown here, so you have to remove significant part of the disc and go for good decompression. And if you leave a loose fragment inside the disc space, which may come out after the surgery, and failure to diagnose all component of the root compression, one can have many components. There can be disc, there can be osteophyte, there can be facet hypertrophy, and there may be ligamentum flavum hypertrophy. So there can be foraminal disc. So many components may be there. So pre-operatively, one should read the radiology very well, and all compressive force on the root or thecal sac should be removed rather than only removal of the disc fragment. The other complications could be bleeding, which can occur from epidural bleeding from above or below the severe stenosis. When there is a severe stenosis, above and below the disc space, there is venous dilatation by the venous plexus, and there may be severe, very severe bleeding. So in such case, there is no need to worry in the lumbar spine. You just put in patties and the bleeding stops. And the other cause may be the abdomen is not free or the patient is there in the light plane of the anesthesia. There may be bleeding from the bone, which can be controlled by bone wax, and if the incision is too big. The other complications may be occurrence of postoperative hematoma. So this occurs when there is a small ooze from epidural space or ooze from the muscle after removal of patties or gauze piece. So proper hemostasis should be done. The other complication is wrong level. It is more common at L45 and L5S1 in lordotic spine as shown here. Slight angulation one can reach at L5S1 and L45, and when the localization has been made wrongly, if there is non-overlapping localizer pins, so both the pins of the localizer should be placed, should be seen at that particular disc level. Excessive angulation of the tubular retractor, or it is too much deep. So the surgeon should alert himself or herself if there's too much of angulation of the tubular retractor. If it is cranially angulated or caudally too much angulated, then it should alert. Usually, if the all planning is done very well, then the tubular retractor should be at about 90 degree. And if your tubular retractor has gone too much deep below the skin, then also there may be wrong level. You might be in between the two transverse process. There is more operative time because of the frequent soiling of the lens by the bone dust or the fluid. So proper corrective methods should be taken, and one can produce unstable spine when you have not properly judged preoperatively. If the back pain is out of proportion to the radicular pain, one should suspect unstable spine, get flexion extension x-rays, and rule out unstable spine. There may be facet injury, especially if there is a foraminal disc and you try to remove too much of facet. So do not remove facet more than half or 1/3, medial 1/3. This may happen in facet hypertrophy. One should try and avoid injuring paraspinal muscles, supraspinous and interspinous ligament also, which contributes significantly in the muscle, in the spine stability. The other complication may be conversion to the open procedure when there is unfavorable anatomy, disorientation, and inability to do proper bimanual dissection, excessive angulation, excessive bleeding, massive dural tear before you have removed the culprit compression. So dural tear with root prolapse, if it is there, you might have to convert to open, or there is incomplete decompression. So all corrective methods should be done. Camera should be oriented before surgery, survey anatomy first, see everything, medial, lateral, all relations. You should be able to do bimanual dissection, and proper training should be done, and avoid complications rather than creating them and then losing a lot of time to treat that complications. Discitis may be seen if you leave large dead space or collection of blood, or there is a sterilization issue. There are advantages of endoscopic surgery, but there are limitations also. And the limitations are that there is a learning curve. There are more complications in the learning curve and more operative time. Transition from microscope to endoscope may be difficult because there are obstacles. One is that there is difficulty in identification of structures because only the part of the whole structures are seen. You don't see all the structures which we see in the naked eye when the large incision is given. They may have difficulty in controlling the bleeding, blind area. It requires unique skill, which requires endoscopic training, 2D images. They may have limited space, more operative time, and so in the learning curve, there may be more complications. And these are the methods which you should use to avoid complications. Choose simple case in the beginning, practice on cadaver, watch videos, take help of your colleague who are expert, and help of mentor in the learning curve. Visit the department to watch expert doing surgery, and you can use simulators. So good case for beginner is when the spinous process is thin and straight and the base of the spinous process is not broad. There's a good interlaminar window. There's horizontal lamina, paracentral disc. The disc prolapse is not subligamental. Sometimes it is extruded outside. So those are the simple cases. And there's absence of posterior dislocation of the root or the thecal sac. And one should avoid cases in the beginning when the spinous process is curved or thick, broad base, small or no interlaminar window, the vertical lamina, subligamental disc, central or foraminal disc in patient who has facet hypertrophy. So in such cases, foraminal disc with facet hypertrophy, you will land in injuring the facet. Central disc one should do after gaining some experience. The root location, if it is posteriorly dislocated, then one should be careful. And when there is severe facet hypertrophy or the compression is by the osteophyte, these are also not the good case for beginner. So to summarize, interlaminar approach is effective and safe in unilateral or bilateral symptoms at single level or multi-level in any migrated disc, lateral, central or extra-foraminal disc, recurrent disc, calcified or fibrous disc. All these things can be done because you can use even osteotome through the tubular retractor, and it can be done at all levels. The results are good, but there is learning curve. There may be little more complications, especially in the learning curve. So one need good training, and in the beginning it is better to choose simple cases. For detail, you can refer to my book, The Neuroendoscopic Surgery, a Comprehensive Approach, and chapter 24. Thank you very much.